My name is Timothy Schultz. Thanks very much for joining. I'm from Business for South Africa. Thank you for joining our webinar today. Our speakers are Professor Glenda Gray and Stavros Nicolaou. We will soon be joined a little later by Dr. Anban Pillay of the Department of Health. Unfortunately, he is unable to make the beginning of this because he is still answering questions in Parliament. When he joins, we will allow him to present his presentation. We are going to structure this in a relatively informal manner, where we're going to put the emphasis on answering your questions. We're going to kick off with a very short presentation by Glenda Gray. Thereafter, Stavros will do a presentation. We will then take questions on the chat function. I will do my best to moderate those and to condense them into specific themes for Glenda and Stavros to answer. When Dr. Pillay joins us, we will then revert to his presentation and then continue with the question and answer session. We are recording this session and we will make it available on the Business for South Africa website. Any further ado, Glenda, can I ask that you kick off, please?
I'm talking to myself here, sorry.
You're talking to us all now. We can hear you.
Okay, so can you see my screen now?
Yes, that's perfect.
Okay, cool. Okay, so good afternoon, and thank you very much for inviting me to present the SAMRC program. Just to remind everybody, this is a phase 3 open label study of a single dose of the J&J COVID-19 vaccine. And this is aimed at 500,000 healthcare workers with a 70-30 split, 70 for the public sector and 30 for the private sector. What is a phase 3 open label study? I think there's been some confusion about it. We are in a space in South Africa where we know the vaccine works. And we're still waiting for the registration of the vaccine at SAMRC. And when we started this program, the J&J program had applied for an emergency use authorization with the FDA, and that happened, I think, a week into this program. So this is the first early access program, and we call it a phase 3B because we are waiting for the registration of this vaccine in the country, and so it is officially not a rollout, it's an early access program or a phase 3B study. If there's any questions about it, we can talk about it later, but there does appear to get lots of confusion about what this is. But the good news is that we've already vaccinated over 92,000 healthcare workers in 16 days, and we hope to reach the 100,000th healthcare worker today, which means that we've vaccinated 1 in 5 healthcare workers. A long way to go. But we've learned a lot in this first phase and how to scale up. We've learned how to sort out the electronic vaccine data system and how to manage the interface between dosing and getting the dosing correct and the vaccinations done in a timeless fashion. So as you can see, Gauteng is leading the pack here. And we have very big programs in Gauteng, obviously very big hospitals, lots of healthcare workers. And then obviously the Western Cape and KwaZulu-Natal are the other 2 provinces that are doing well. We are putting some more capacity in the Eastern Cape to try and increase vaccine coverage there. And this is because the Eastern Cape were very heavily burdened by the COVID epidemic in the last wave. They're very important for us to make sure that there is capacity in the Eastern Cape and make sure that we can get the healthcare workers in that phase. Sorry, I'm having a problem with my button to advance to the next slide. But there we are. So just to say that in terms of the vaccine program, there are 3 phases to the vaccine program. The phase 1 is aimed at the healthcare workers, and this target is around 1.25 million. And so our early SAMRC program will get to just under half of the healthcare workers in this first phase. I think both Anban and Stavros will talk a little bit more about the phase 2 and the phase 3, but obviously phase 2 is to still target the essential workers, people in congregate settings, people over 60 and people with comorbidities. While and then the last phase obviously is to mop up the rest of the population. And this will be done, you know, in public-private partnerships and with a whole lot of people. We need all hands on deck to be able to achieve this ambitious task of doing a wide-scale and rapid vaccination program in adults in our country. So this is just a summary of where we are. We in a highly constrained supply situation at the moment, using the J&J doses. And obviously we're doing this trying to focus on front-facing or patient-facing healthcare workers and to administer this under study conditions. And obviously as the supply increases and as more vaccines get registered in the country, then more access will occur. And obviously to end with the continued vaccination in the future. So I think I'm going to stop there, Stavros, because I think it's probably more important to hear what the questions are and specifics around and technical specifics around the vaccine program, rather than continue to show slides. So I'm very happy to take questions after you and Anban have presented. Thanks.
Thanks very much, Glenda. Can I remind everyone to please turn off your cameras? It'll improve the connectivity. And Stavros and also everyone, please maintain yourselves on mute. Stavros, over to you.
Okay, thanks very much, Tim, and good afternoon, colleagues. I see there are over 415 people, I think, on the call. Purpose of today's webinar is really twofold. It's part of Business for South Africa's ongoing commitment to regularly and frequently update various constituencies, including this constituency here, which is made up largely of business people and our colleagues from mainstream media. These regular feedback sessions, of course, will update what is a very fluid environment and continues to be fluid. So the information that we provide today is current and as best as we can, with an understanding, of course, that the situation changes not only here in our country, South Africa, but globally. It changes minute to minute. I'd like to cover, Tim, if I may have my slides up. I'd like to cover two aspects today. Firstly, where business is with the phase 1 rollout. And then I think the more important conversation is how we are gearing up and focusing on phases 2 and 3, particularly phase 2, of course. Colleagues on this call will recognize that in January, our government put out a 3-phase approach to achieving herd immunity. Herd immunity would be the epidemiological endpoint of the pandemic and would involve vaccinating 40 million people. Very complex and an initiative that is of an unprecedented scale. Business for South Africa from the outset has been working alongside government to deliver vaccines, to assist with the rollout. Of course, this program is government-led and we continue to support and, where necessary, complement government in this national effort. Let me update you where we are with phase 1. Of course, phase 1 is the phase that constitutes 1.2 to 1.3 million healthcare workers. The hierarchical flow of the vaccine program commences firstly with healthcare workers, of which are 1.2, 1.3 million. You then move into phase 2, which is your essential workers and high risk population. That's about 18 million people. And then phase 3, of course, is the rest of the population. So on phase 1, Business for South Africa has supported efforts for both the arrival of initially it was the AstraZeneca vaccine, We all know why there was a pause button pressed with the AZ vaccines, but we were able to work with Glenda and her team with government in providing an agile and nimble, we called it a repivoting of the program, which enabled the J&J Sisonke program to be implemented. Glenda's explained that in detail. I think we all know the effort that had to go into that. So Glenda and her team really need to be commended for pivoting this in a completely different direction, but more importantly, for getting shots in the arms of healthcare workers well ahead of the anticipated and dreaded third wave. To date, in this, Glenda's given you more updated numbers. These were numbers as at Tuesday evening. 83,000 healthcare workers had been vaccinated. It's more closer to 100,000 now, and 1/3 of those are private sector healthcare workers. You'll all know that these J&J clinical trial doses are received on a consignment basis of roughly 80,000 doses per consignment until you build up to eventually 500,000 doses is what J&J have committed to in terms of this clinical trial material. And with each consignment, we look to either reconfigure or expand the sites, the vaccination sites. So at present, 13 private sector sites have been identified to complement some of the existing sites. As we work through the consignments of 80,000, of course, we will continue to either expand and or rotate the sites so that you are vaccinating catchment areas that bear both high frequency and or higher risk. Lastly, of course, there's still speaking to phase one, you will all recognize there's a significant IT coordination element to all of this, primarily driven through the EVDS system, which has now become a household acronym. And B4SA has made available a consortium of chief information officers from large private sector companies, both healthcare and non-healthcare companies, to support the rollout through the EVDS system, and at all times seeing how we can increase its applicability, but also how you make it increasingly fit for purpose. So that covers our phase one update. Let me move into what's planned for the weeks and months ahead. Of course, phase one, in a sense, is the easy bit to do. Things become a lot more complex and the scale increases significantly when you start moving into phase two. So where are we with phase two, the way we understand it as Business for South Africa? From a supply pipeline point of view, it looks like we've secured, including the Johnson & Johnson clinical trial material, the Pfizer stock that's been promised. And of course, you would have heard President Ramaphosa almost 2 weeks ago now announced that there were 11 million doses. These are single doses of J&J product, understanding that J&J is a single dose shot and Pfizer is a double dose shot or a dual dose regimen. So understanding all of that, if one were to aggregate what we understand the country has committed to across Pfizer and J&J, we would be able to receive enough doses for 6 million lives by the end of June. So that's the end of quarter two. Our estimates at Business for South Africa, if we were to look only at healthcare workers and what we would deem to be a high-risk population, I won't go into the detail of how that's been assessed. There's been a team that's worked extensively on that. We would need to have vaccinated between 7.6 and 8 million lives in our country. So that will indicate to you that there is some deficit at the end of quarter two. We continue to work closely with government in attempting to accelerate how we can secure and or land more doses of vaccines in Q2, which is the critical period. Why Q2? Of course, because we are anticipating a third wave. There are no experts with COVID, so no one can predict reliably when and if a third wave would come along, but suffice to say that a third wave is imminent as people start moving around the country and you start having some super spreader events over the Easter holidays again. And as you move into the colder winter months, you would anticipate an upsurge in cases. The strategy remains very much denting the mortality curve and not overburdening the hospitals. And that fits in with the risk categorization or stratification that I mentioned earlier, that sort of looks to 7.6 to 8 million lives, as I said earlier. So we recognize there is a gap in Q2. We also recognize the way we understand the supply pipeline. There are extensive doses that would land in Q3 and 4, and some in Q1 2022. And that would mean we don't really have a problem with securing the number of doses. We've got more a short-term problem in Q2 in vaccinating as many people as we can prior to the much dreaded third wave. So hopefully that places in context where we are from a supply point of view. Let me make two final comments. Again, just speaking to the risk stratification that led to that 7.6 million lives that we're estimating. I think some stats that are important in that consideration. And of course, as a country, we haven't yet settled who constitutes the risk classification or hierarchy in phase 2. We haven't settled that. Ministerial Advisory Committee are working on that. We are going to be giving further inputs into that, but just note the following statistics in the meantime while you might want to consider this. The elderly are 3 times more likely to be hospitalized and 50 times more likely to perish from COVID. Second stat we want to flag is people with diabetes and those who are HIV positive have a 50% higher administration risk, that's hospital administration risk, and a 90% higher mortality rate. Thirdly, people with 3 or more chronic conditions have an 80% higher admission risk and a 50% higher risk of mortality. And then, of course, if you look at the common denominator across all of these stats I've just given you, age is a very important consideration, and we are advancing a case that age should be the predominant factor in determining the hierarchical rollout of the vaccine in phase 2. Finally, the biggest challenge unquestionably remains how we scale up vaccine sites en masse and have an appropriate number or commensurate number of vaccinators that are able to administer these vaccines. This is not confined, incidentally, only to corporate pharmacies, GP practices, businesses with occupational health facilities, but it's going to require solutions around mobile clinics, using stadia, town halls, and other similar facilities in order to ramp up our capability in the short to medium term to 120,000 vaccines a day. And then eventually, if we are to get to 40 million people vaccinated, we would have to ramp up to 250,000 vaccines a day over a sustainable period. So hopefully I've given you a sense of where we are with phase 1, what the outlook is on phase 2, and what is required in order to meet what are very ambitious targets, which can be met, but only if we cohere, mobilize, and all the available resources in our country. Thanks very much. Back over to you.
What's up, Chris? What's up, Chris?
Thank you very much, Stavros. Just as a reminder, Can I ask everyone to please mute themselves so we don't have all of our conversations competing, and also to please turn off your cameras. That will improve the connectivity for everybody. I can still see a number of people with cameras on. Glenda and Stavros, there's a very large number of questions on there, so I'm going to just bunch up a few of them. Firstly, Glenda, could you please just talk us through the expected time frames? There's quite a number of questions about when do we go from stage 1 to stage 2 to stage 3, and if you could talk us through that process, the best information we have now.
So thanks for that. So I think the expected timeframes, and I think Stavros could also confirm as well as when Anban gets on. But obviously, we know that the J&J agreement has been signed with government, and there's a regulatory process that is underway to ensure that the vaccines can be shipped to South Africa, and I guess that will happen over the next couple of weeks. So I can't tell you the exact time frame about the J&J. As far as the Pfizer is concerned, also I think it's similar timelines. Is that the first thing we have to do is do the regulatory hurdle, and I understand this is going to be a Section 21 application, and I think it's imminent, the Section 21 application for Pfizer, and that will then mark the first tranche of vaccines. If I think if we keep to our timelines, these vaccines should be in the country, by the end of March, early April, and maybe Stavros can confirm that. But I think that's the kind of timelines. I know people are saying that the 500,000 doses to healthcare workers we're going very slow, but you have to realize this is under study conditions, and so the ramp up will be much faster when these vaccines are registered in the country. So the reason why it seems like we're taking a long time is because we have to do it under study conditions, and so that does slow down the process. But once these vaccines are registered, these processes will speed up rapidly and will be available beyond the research sites and where we are. Once there is a Section 21 registration, there will be easier access to the vaccines and easier distribution mechanisms for it. So I think it's just this first initial hurdle that we have to go through because it's a phase 3B program.
Just before Stavros jumps in, Glenda, there's a question also about the nature of the trial. Will there be placebos? Is every vaccine an actual vaccine?
So the phase 3B is a post-efficacy study. So we know that the vaccine is efficacious. So it's an open label, a single jab vaccine with no placebo, because we know the vaccine works. So this is not a placebo-controlled study. Everybody who gets the vaccine gets the active vaccine and no placebo. It's called a 3B, as I mentioned before, is because we know that it's effective, but we haven't. The vaccine has not been registered in the country, so we're operating in a phase where we're using what we call an investigational product or research material to deliver the vaccine that is known to be effective before the registration occurs. So it's an early access program prior to registration.
Thanks, Glenda. Stavros, could you possibly expand a bit more on the likely timeline, not just of the procuring of the vaccines, but also of the capacity to roll them out through stages 1, 2, and 3? Phases.
Okay, Tim, thanks very much. And I know we've also been joined by Dr. Anban Pillay. He is on, and I'm sure he'll want to make some comments around this, but I'm just going to reinforce some of the timelines that I indicated earlier. And these are as best as we understand them, of course, remembering that there are significant global constraints to supply vaccines, and that timelines are reasonably fluid. But the best we can understand the situation, and I'm going to talk in lives here rather than than doses, because some of the vaccines are single dose and other are dual dose, as I said earlier. So our understanding is that in Q1, which is the quarter we are presently in, which ends end of March, we have around 700,000 lives secured. Okay, now that doesn't mean these are shots that are going to be administered. This is forecasted stock to arrive in the country. Okay, and then we move into Q2, which is a critical quarter, as I said earlier, and there the number increases to 5.3 million lives. So you get 6 million lives of landed stock equivalent that would land in the country by the end of Q2. Okay, and then quarters 3 and 4 give you at best estimate right now in excess of another 20 million lives that would be covered. So that's the best we understand the supply pipeline as it stands at present. And perhaps Dr. Pillay wants to add to that, Tim. Thanks very much.
Thanks, Stavros. Dr. Pillay, I've unmuted you. If you are able to, we said before you joined that we would do the presentations, then take some questions, and when you joined, we'd revert to the presentation. So if you are able perhaps to answer add to the question that Stavros was answering, and then do any presentation that you have. Once we've completed that, we can revert to the Q&A session.
Thanks very much. In fact, my presentation intends answering that question as well. So maybe if I can go directly into it, it may be easier for saving time.
Fantastic. If you can do that, please. And can I remind everyone to please turn off your cameras? It improves connectivity, and also to remain on mute, please. Thank you.
So I think it's important just to reflect on where we are and where we're going. So we're in phase 1, and we have a target of about 1.2 million healthcare workers that we need to vaccinate. I'm sure Professor Gray spoke to you about the study, the phase 3B study, and these are the doses from Johnson & Johnson. Clearly, this would be a maximum of 500,000. So we would need to top that up, and our plan is that we would be getting in Pfizer vaccines in order to close that gap that will exist once we finished with the J&J doses. We're estimating that we will complete this process by mid-April, and so by the end of April, early May at the latest, we will then start phase 2. Phase 2 is essential workers. Now, I know there's been much debate and lobbying around essential workers, so we will certainly come out with an explicit list of who's essential and who's not. The Ministerial Advisory Committee is trawling through that. I know there will be some people who will be unhappy, but the reality is, given the flow of vaccines and the doses, it's important that we identify those at highest risk first, and will play an essential role in terms of making sure the wheels of the country turn, are identified and vaccinated first. The second is the group around congregate settings, and these are largely those that are living or working in settings where they are in close proximity to other persons, and so the risk of transmission remains high in that context. The third is the elderly, that is those over 60, and the fourth, persons with comorbidities that have been linked to high levels of morbidity and mortality when they contract COVID. Now, we plan to run all 3 of these groups in parallel. What we will be coming out in the next week or so with is very clear subgroups within each of these categories to identify which essential workers will we go with first, second, and third, etc., and in the other groups as well. Here we're looking that we would be getting Johnson & Johnson vaccines coming through. The commercial doses should be available in Q2. In addition to that, the Pfizer doses that we receive in Q1 will continue into Q2. And so we think that we would be able to top that up and run the program based on that. Then in phase 3, sorry, we would then be basically vaccinating everybody who's over the age of 18 who didn't fit into phase 1 and phase 2, who would be keen to be vaccinated. And that's broadly speaking the strategy we're using. Here again, we'll continue to use the J&J vaccine and Pfizer vaccines. If there's a need for us to procure additional vaccines from the other suppliers, we would certainly be doing that to top up any additional need that may arise, or if one of these suppliers have problems in terms of production or supply. We've seen some of those challenges in Europe already, and so we should anticipate that may happen here. And then just to say, in terms of our phases, our phase 2 will use multiple delivery sites. I know many people are asking the question, we're moving very slowly currently. Well, relative for a trial, Glenda's moved very fast, but that's done in the context of a study, and so you need to adhere to the study conditions. However, in the context of a rollout program, a full-on rollout program, we would have multiple options or sites where we'd be vaccinating. So clearly our healthcare facilities will be used for vaccination, and these would be our clinics and our hospitals. We would also, in addition to that, be using vaccination centers, whether they are pharmacies, whether they're GPs. We'd even be using stadia or halls where those are appropriate, particularly in the more urban areas. In addition, there will be outreach programs that will be in place, particularly for our more remote rural areas where it may be difficult for people to come to a common point. The Northern Cape is a typical example of where we'd probably want to do that. And then fourthly, work-based programs. So where essential workers are working in a particular environment, whether it's mining or any other industry, they probably would have an occupational health clinic on site or some kind of service. We would then want to go to that facility and use that as a basis to vaccinate all workers within that environment. So we think that these multiple approaches to trying to vaccinate will certainly increase our pace and number of vaccines in order to get to numbers that are several thousand per day, so that we can get to our target in terms of vaccinating all adult South Africans by at least the end of the year or early next year. Thank you. I will stop there, Chair.
Thank you very much, Dr. Pillay. I'm going to come straight back at you with a question that was posed earlier, which is about the different facilities that are going to be used as vaccination sites. How are these going to be vetted? What is the protocols that are going to be applied?
The different facilities that will be used will require compliance with some minimum standards. Those have been put out to the provincial departments, and we would certainly be communicating that to the other facilities as well. I think the colleagues that are working through the B4SA team as well have had sight of these requirements, but we would be making sure that facilities assess themselves against these criteria and confirm whether they are able to comply or not in terms of this.
Thank you. There's also another question before I return to Stavros about the private sector's participation, and this is about the Sisonke registration, about who's able to register and who is not able, and how that works. There's quite a detailed question on the chat. Perhaps if you could talk us through the Sisonke registration, please.
Sure. So this is okay. Sorry, yeah. Go.
Glenda, go ahead, Glenda, first, and then I can help after that if necessary.
Yeah. So we work with the electronic vaccine data system and the Sisonke interfaces with that. And you have to be a healthcare worker first of all to be eligible for participation. And we work with the local hospitals and clinics where we're working to come up with an agreed definition of who goes first. And we normally look, say at Baragwanath Hospital, we work with their, through their, this, I'll give you an example of Baragwanath Hospital because I think it's the easiest, is that we would work with the institution's lists. In the Western Cape, there's also another process where there's a list that's been made up by the province, who then get these healthcare workers then get prioritized. We try and prioritize obviously anyone who's patient facing, and this doesn't matter if you're a porter, a cleaner, or a nurse or a doctor or a dietitian. We try and make sure that anyone who's patient facing, who's in ICUs, who's working in COVID wards, in emergency rooms, or in high density patient facing areas, is prioritized with it. So it's a healthcare worker that's interfacing with the public, and particularly trying to prioritize people who are working in COVID wards, emergency rooms, and ICU. So those are important. But they're any category of healthcare worker. If you're a security guard, a porter, or a cleaner, and you're working in those areas, then you're also considered to be critical for vaccination. We have tried to make sure that people who get vaccinated come with their personal number, their registration number, or proof that they are working in the setting. We know there have been some loopholes that happened in the first part of the program, and sites are now getting much stricter in making sure that only the critical people who should be vaccinated are being vaccinated. And this process will be ironed out, and we will make sure that there are no loopholes, and to make sure that the critical healthcare workers get their vaccine first.
Thanks, Glenda. There's two follow-up questions on that. I just want to deal with them before we move on to Dr. Pillay. Firstly, someone has said that their healthcare worker was registered but only got a voucher number. And the second question is, second phase of the vaccines, will the target group also be expected to register on the Sisonke system?
So, those are two good questions. So when the Sisonke study is over, when we've done our 500,000 healthcare workers, then people won't have to register with Sisonke anymore, because the study will be over and we'll have had our sample size and our doses. If you have your voucher, there are two ways that you can redeem your voucher. We've implemented, or in the process of implementing, appointments. And so you'll get your voucher, and then in certain provinces and in certain institutions, you will get a time to come between, say, 10 and 12, and you would go there and redeem your voucher. In other parts, in other parts we accept walk-ins. So if you have a voucher, you can come to the institution that's vaccinating. You can show them your voucher, and we accept at this moment in time 40% walk-ins who don't have an appointment. As the appointment system is implemented, the walk-ins will get less and less, and we hope to get to a point where we accept 90% appointments and 10% walk-ins. But this is a moving target, as a lot of healthcare workers are come to the set center, and some of them don't like using the appointment processes. So we're trying to change this. I think for the rollout, for the big rollout for phase 2 and phase 3, you're going to have these appointment schedules, so that you don't run out of vaccine and you don't run out of vaccinators. So I think in the future, appointments are going to be critical for the success of the broad scale rollout.
Thank you, Glenda. Dr. Pillay, do you want to add anything to that answer?
No, I think Glenda's covered the key issues. Just to say that we need to obviously have these rules in place, because we want to identify the high-risk people and vaccinate them first, so that we protect them and then move down to the other levels of risk. Yeah, thanks.
Thank you. Stavros, can I bring you in? There's a couple of questions about the role of the private sector and private medical aids. Could you talk us through what role the medical aids are likely to play, the best information we have at the moment, and likewise whether the private sector will be able to procure and administer the vaccines?
Tim, thanks very much for those two questions. I guess the starting point here is whether we private or public sector, we all aim to achieve the same objective. The objective here is to vaccinate as many people as swiftly as possible. And all available resources and platforms that are available to achieve that objective need to be mobilized, as I indicated earlier. We also recognize, however, as business, that in order to achieve herd immunity, which is the ultimate objective of our country, we need to have a strong prescription towards social solidarity, so that you do get an even distribution of vaccines. If you have an uneven distribution, of course, you're not going to achieve herd immunity. So our feeling is that certainly in the initial phases, as it's set up currently, the private sector would be procuring or buying vaccines from government. Government will certainly in the initial phases be the procurer of these vaccines. I think that's been well documented.
Sorry, but we can't hear anything.
Sorry.
There's no sound.
Stavros, you went quiet there for a minute or two. Could you rewind a little and...
Okay, sorry about that, and I hope I'm audible now. Okay, so
yes, you're good
what
to go.
I was saying, let me just very quickly cover what I was saying, is that the private sector will be buying the vaccines from government, certainly in the initial phases. The exact modalities of that are currently being worked out, but suffice to say that private sector facilities, whether these are corporate pharmacies, independent pharmacies, GP practices, etc., will be buying stock from government for both private and public sector patients. The modalities, as I said, of that are yet to be worked out. The role of the medical schemes is a very important consideration here. The medical schemes have come out publicly and said that they will be funding the cost of the vaccine. Now, the cost of the vaccine includes the vaccine itself, the ancillary equipment, so that's your needles and syringes, and then of course there'll be a fee for administering these vaccines. So schemes have indicated they will be covering this. The Council for Medical Schemes have made this a PMB, prescribed minimum benefit. So the intention is that medical aid patients will be covered when vaccine is administered to them. There are also ongoing discussions between the private and the public sector to see what role the private sector can play in the future funding of a vaccine. Those are ongoing discussions, and I won't delve into those today until there's greater clarity. Thanks very much, Tim.
Thanks very much, Stavros. There's also a number of questions about non-healthcare workers or healthcare workers who are patient-facing, support staff, and so on, who are struggling to get onto the EBDS system. Could perhaps Dr. Pillay, perhaps you can explain how one would get people onto the system if they're being rejected?
I haven't heard of people not being able to get on. I think where they are having difficulty is whether they're getting a voucher or not, and that depends largely on where they are working. So if you're patient-facing but not within the risk groups that I think Glenda spoke about earlier, then you are less likely to get a voucher at this stage. As I said, the strategy is to identify those healthcare workers in the highest risk category to be vaccinated first in the environment. And once those healthcare workers have been vaccinated, then you go to your next risk category. So healthcare workers, when they do register, they do indicate which category or which area they're working in. And that then determines whether the voucher will be issued to you at a particular time or not.
Another question related to EBDS, and it's just whether it's going to be able to cope with the volumes when we get to phase 2 and phase 3. What comfort can we give people that it's going to have that capacity to scale?
Well, I suppose that we will find out soon enough, but the team that works on this has stress test the system, and they've said to us that it will certainly work. And we obviously have faith that that's what would happen. But I do think that we will be monitoring the system now during this period to understand how things are going, and if there's any problems, we obviously have to fix it.
Thank you very much. Stavros, you'll see there's a couple of follow-up questions about the private sector's capacity to procure vaccines. I'm not sure if you've managed to read those, but perhaps if you could look at that. So what is the exact legal impediment or lack thereof? And what about industries that want to make vaccination compulsory for their staff when they are available?
Okay, so Tim, I think there are 3 questions there, so let me respond to all 3 of them. Let me start with the latter question. I think firstly, as the President indicated in his family meetings, or so-called family meetings 2 Sundays ago, the vaccine is not mandatory at this point in time. There are certain pediatric vaccines, not COVID, that are mandatory in the country, but this is not the case as yet. And my colleagues, Martin Kingston and Kaz Kavadia on this call are significantly engaged in NEDLAC, where this is a discussion topic, but certainly as it stands right now, it's not mandatory. Secondly, let me talk a little about the private sector's capacity. And when you talk capacity, I think you're talking 3 things. Firstly, capacity to procure. Secondly, the logistics and supply chain capacity. And then thirdly, the capacity to deploy and administer the vaccines. The logistics capability of the country, according to the phased pipeline of product that we're anticipating, and remember what Dr. Pillay said earlier, we don't have full line of sight and visibility, particularly when you move into quarter 3 and 4. We know that we're expecting a lot of vaccines in, but don't know the exact quantum. With the Pfizer J&J mix, and of course this could change as other vaccine options become available, our current best estimates from our logistics colleagues is that we can cope with the present quantum that is being looked to be secured for the country. So we do have the capacity and the capability to move these vaccines around the country. Understanding that in peak months, you're going to be moving anything between 4 to 6 million doses of vaccine. The capacity to administer the vaccine at anything between 250 to 300,000 vaccinated patients a day, we know is a significant stretch. But just to give you some type of example, and I see colleagues like Ivan Saltzman from Dischem are on this call and others. Last year, during the flu season, corporate pharmacy, corporate and independent pharmacies administered in a period of 5 to 6 weeks, 1.3 million doses of flu vaccine. So that gives you a sense of what we are capable of doing. Of course, this is at a much bigger scale, and we are going to require additional capacity through mobile clinics, the stadia, town halls, and others. So if we get all of that right, we can accommodate the 250 to 300,000 daily vaccines that will be required to be administered. Okay, and the last point I want to make is around the regulatory, the regulatory aspect of who can purchase a vaccine. Firstly, and I think government have clarified this, there's nothing that prevents licensed private entities from procuring the vaccine. Licensed private entities mean that you have to be registered and licensed with, if you're a pharmacy that's buying this, either with a pharmacy council, and then there's a requirement that you have a SAPRA license as well. And if you are a GP practice that's looking to buy, you would have to have similar licensing, except it's from the HPCSA instead. Of course, you can only procure product that is registered in the country, and none of these vaccine options are registered as yet. And that's why Pfizer is coming in under Section 21 dispensation, and the initial J&J doses arrived under clinical trial conditions. And then finally, as I indicated earlier, the preference and what's logical is certainly in the initial phases that the private sector, provided they are licensed, and I need to be clear on this, that if you're a non-licensed facility, you cannot buy these vaccines, whether it's either directly from government or any other source. So the preference here is that in the initial phases, we buy from government through the mechanism I described earlier. And I also think that when we look at procurement outside of those channels, we should be aware that there is already fake and counterfeit contraband product that's doing the rounds, not only in our country, but globally. And we just need to be vigilant around the integrity of these supply channels at all times. Thanks very much, Tim.
Thanks, Stavros. Now, a question perhaps for Professor Gray and Dr. Pillay. We see there's capacity to distribute the vaccines or to purchase them and then to distribute them. But what about the storage of the vaccines, particularly because they are having to be stored in very cold conditions? Are you able to expand on that, our capacity to manage that?
There has been an audit in the country looking at minus 70 refrigeration capability, and the you know, for Pfizer, you know, so I think we're the only country in Africa that has this kind of capability to manage a cold chain that is required by the Pfizer vaccine, and so the audit has shown that the country does have, even in rural settings, has a minus 70 refrigeration capability, and that's also why there is an interplay between the J&J and the A26 vaccines, because obviously the A26 vaccines require less refrigeration and may be easier to use in more rural settings or where there is no minus 70 refrigeration. So you know, that is probably how one of the ways to manage the areas in the country where there is no minus 70 refrigeration capability. But I also have been seeing a lot of innovation, and maybe this is where Stavros can come in. I've been seeing a lot of innovation around cold chain management using minus 70 innovation that doesn't require the kind of electrification. And there's been a lot of, I've seen a lot of innovation happening to try and address the issue of the minus 70 refrigeration where places in the country can't guarantee that.
Stavros, are you able to build on that answer?
Yes, I can. Thanks very much, Tim. So firstly, I agree with Glenda in that if I look at the present mix of products we've got, that's Pfizer, J&J, we can accommodate both the cold chain management and the general logistics requirements. I think most people on this call will also know that Pfizer have have provided to regulators, not only in our own country, but around the world, additional data in terms of the storage requirement of their product, which will make it easier from a cold chain management perspective. And then thirdly, as Glenda says, there are a number of innovations. Some are as basic as a dry ice packages, and some are innovations that have been created or innovated in the United States by a South African, funny enough. So there are these new innovations. So I think all told, what's important here is the current mix of products at the quantum that we've got. Our logistics colleagues, many of whom are on this call, like Mervyn Naidu, for example, are confident that we can ship this product around, both the Pfizer and the J&J for that matter. Thanks very much.
Thank you, Stavros. I know we're approaching the end of the hour, but if I could ask the speakers to just stay on for a minute or two more and to give your final thoughts. Before we do that, Dr. Pillay, there's a question for you. If you are able to update on the status of the tender for the logistics provider, and then separately, are you able to explain at this point how we are going to communicate who is eligible for the next phases, which will be a far more complex task than the healthcare workers?
Thank you. So I think on the tender, what I can share is that the tender had closed, and they're currently in the process of evaluation. It will then go to adjudication before there's any award. So we're probably talking a couple of weeks at least for that to happen, to make sure that due process is followed and the evaluation process takes account of all of the bids that have been submitted. So that's my sense about the timelines. I'm not directly involved in those processes, so I can't give you exact dates or anything like that. In terms of the other issues that you raise of the groups in phase 2 and phase 3, we'll certainly be probably in the next week or two providing a lot more detail around who will be the essential workers or the congregate settings, etc., or those with comorbidities that we're actually referring to, so that they can understand, and then we would encourage them to register thereafter and make sure we start the rollout for those groups. So certainly in the next week or two, they will certainly be hearing details around which groups would be included, etc. Thanks.
Thank you very much, Dr. Pillay. I see people are starting to drop off, but we still have quite a high degree of attendance. Could I ask each of the speakers now just to wrap up any final comments or thoughts that you want to convey, and then we will close off. What I can say to everybody who is still on, we are going to be doing further briefings such as this. The Department of Health is also doing a number of briefings. So this is the beginning of a dialogue that B4SA will also be participating in to try and answer all of your questions as they unfold. Glenda, could I ask you to please give a summation of your thoughts? Then we'll move to Dr. Pillay, and then Stavros will end off with you.
Yeah, and I think the most important thing about this is to continue to innovate. So on day one, you need to keep on learning and keep on changing your processes to become more and more efficient and more lean. And so we can expect hiccups and hurdles, but the important thing is that together we change it and make it better. And so we've learned in the last 17 days, every hour we're improving the systems. And I think the most important thing is to continue to work on improving the system, so that by the time we get to phase 2, we've understood all the hurdles and the need to scale up. So it's not perfect, but it's definitely much better than it was on day one. And we're going to get better and better, and people must just be patient as we scale up. This is a huge commitment to do this, and we just have to make sure that we adapt and we learn and we change every hour.
Thank you very much. Dr. Pillay?
Thanks, Samiti. Yes, I think it's important to appreciate that we, on the 1st of February had found out that, look, we're not going to be able to roll out the AstraZeneca, and there was a massive, response from a number of people who just came together and tried to support this. And I think Glenda and her team, and then Abida, who's on this call, who made the mammoth effort to try and get us doses in a short period of time. And by the 15th, we were already starting vaccinations. So I think we just need to reflect on the work that's been done and how quickly it had been done and what it normally takes to get us to this point. So clearly there will be challenges, and I think we all appreciate the challenges that we have, but I think as a collective, we need to work at it to make sure we fix those problems. And clearly our pace of what we're vaccinating now is at the pace of what can be allowed in terms of a study, bearing in mind that once we get out of the study, we can open up many more sites, and I think the pace will be much faster, and people will understand that access is much better. And then phase 2 clearly will be much bigger rollout with much more vaccines being available in quarter 2. The manufacturers are anticipating having much more doses available. So I think things will certainly be picking up pace and accelerating during that period. So I think we need to remain positive, encourage people to be vaccinated, and make sure that when we identify problems, also think about what is the solution so we can solve this, because it's only our collective effort that can solve this problem. Thank you.
Thank you very much, Dr. Pillay. And Stavros, we'll give you the final word before I wrap up. You're on mute, Stav. No, we're still not hearing you.
Okay, am I audible now?
There we go. Yeah.
Okay, apologies for that. Okay, Tim, thanks very much. And I think my closing comments are consistent with those of both Anban and Glenda. I think what we need to flag here is, again, that this is a project and/or initiative of unprecedented scale and complexity, never previously been experienced in our country. But I think what we should always keep uppermost in our mind is it's not that we have no experience with vaccines in the country. We distribute and administer on an annual basis over 14 million doses of vaccines. Most of them are pediatric vaccines, incidentally. We do that quite efficiently and effectively. Most of it's through the public sector. So I think we can all take a lot of heart from the experience that we have got, the existing experience and capacity. And then, of course, if we add on the private sector capacity and capability and some of the additional measures that we would be looking to add by way of capacity, i.e. mobile clinics, the stadia, etc. And I recognize there's a lot of work that needs to be done before we get there. But I think if we start aggregating all of that capability and capacity, I think we can pull this off as a country. We should also take some time to learn from overseas experiences. I know we're often very critical of our own circumstances here in our own country, but I've been on calls with some of the EU ambassadors this week, and I can tell you things are not exactly running smoothly in the EU. You would have read about it in the press. They have low uptakes. They have shortages of vaccines. The delivery times are not being met. So there are a number of concerns that the EU is experiencing. I think what's important for us is that we learn from these experiences and we implement them in our own country here. I also recognize, just lastly, that there are a plethora of questions we couldn't get through today. The orientation of today's webinar was very much by way of an update, primarily focused on the logistics and the numbers. I recognize there are a lot of clinical questions and need to probably have a follow-up webinar with some of the clinicians to answer some of the more clinically orientated questions. We could have done that today, but that wasn't the primary purpose. So I think our undertaking is that we will frequently and regularly, and when we have updates, communicate with this constituency and others. Thanks very much.
Thanks very much, Stavros. There's just actually one question I would like you to address. I realize it hasn't come up, but I do think it's important, which is the problem of fake vaccines. There's criminals importing and selling them, which is a great danger.
Thanks, Tim. And I just couldn't help reading the last message that came through, and someone said they're feeling very proudly South African after this presentation. And I mean, that's really great, because I think we all have to pull together to make this work and make it happen. So that's a great message. Thanks very much. And that message also speaks to the question you've just asked, Tim. Of course, we know the risks of fake, counterfeit and contraband medicines. They can disrupt any program, let alone one of this size and magnitude. The best way to manage counterfeit products is through effective track and trace devices. My logistics colleagues on this call could have gone into some detail around that, but the distribution and logistics companies that are going to distribute these vaccines have all got fairly sophisticated track and trace capabilities. They're not fully activated yet, but they will become activated. And it was also a key consideration in the logistics tender that Dr. Pillay spoke about earlier. So I think what we need to do is two things. Firstly, allow the experts to distribute these things, these vaccines, because they have track and trace capability. And secondly, where we do find whether there's fraud, corruption, counterfeit product, or whatever the case is, we need to draw that to the attention of the authorities immediately and report these things, because there's nothing worse than administering a vaccine thinking you're protected and you're actually not. But I'm confident that we deal effectively with counterfeit products in our country and will continue to do so. Thanks very much, Tim.
Thank you very much, Stavros. And also thank you very much, everybody, for joining, and to Professor Gray and Dr. Pillay, thanks so much for your time and expertise. As Stavros said, we will be holding more of these briefings along with the Department of Health and others. We will also endeavour to put a recording of this up on the Business for South Africa website. Thank you very much, everybody.